Welcome, everyone, to our AI and Healthcare Special Edition. Today, we're joined by three people who are heavily involved in the healthcare industry and artificial intelligence. And we're going to have a broad-ranging discussion of current state of healthcare and AI and other matters around all of that. Today, we have with us Tim Rice. Tim ran one of the premier healthcare systems in North Carolina, Cone Health, won many awards for his leadership and healthcare quality. Tim was also nominated to the National Center for Healthcare Leadership and has been heavily involved in national healthcare issues. And we have Jay Goss, and Jay is a partner in Wavemaker, a healthcare venture capital firm based in Pasadena, operations all over the world. And then we also have Matt. And Jay, I'll let you introduce Matt.
Great. Thank you, Dennis. It's great to be here. I'm pleased to be introducing Matt. My firm met Matt back in 2018 or 2019. Matt was running a company that our fund invested into, an early stage healthcare technology company, which is all we do. And Matt was the founder of a company called Evid Science. We invested in that company and had the distinction of becoming our first liquidity event. Matt sold his company to a company called Genesis. Matt's got a real strong background in AI. And then as Matt freed up from the company that acquired him, as AI was becoming a bigger and bigger thing in healthcare, we went and did a full court press to try to get Matt to join our firm in some capacity. So as of about 3 months ago, Matt's sort of the head of AI for Wavemaker 360 Health, helping us do a better job evaluating artificial intelligent technologies for the healthcare industry.
So thank you all for being here. Why don't we kick off with a question? Any of you can start with, what do you view as the most major challenge to healthcare in America today, and what do you view as the greatest opportunity?
How do we afford all these new technologies and things we want to put in place? For instance, the GLP-1s, I was talking to an executive at Cone Health, my old shop. If they had opened the door on GLP-1s to all the people with obesity that might want them in their 14,000 employees, it was a $75 million spend.
Right.
So they have limited GLP-1s just to the diabetic original indication until something happens on the price side. Similarly, Thomas Jefferson Health System has just announced this past week that they're going to limit those now just to diabetic patients because of the expense. And that's typical of a lot of new technologies in healthcare. It comes out the gate very expensive. My old CEO from years ago used to say we can't, have both the cost and the quality that we're trying to achieve. I spoke to a group of community leaders, Dennis, that you know well. I spoke to them Tuesday, and that question kept coming up is we have about a 4-year gap in life expectancy in the United States versus the rest of the well-developed countries. And so what are the reasons behind the gap? Why are we not good at preventive care? Why is it so expensive? So I kind of start with that as a question that came from the community is what can we afford? And why is our quality not as good and our outcomes not as good when we have this huge expenditure in healthcare?
Yeah, it's certainly both sides of Dennis's question. The folks at the Kaiser Family Foundation put out data, I think it was last year, that looked at different age groups, 65-year-olds, 75-year-olds, 85-year-olds, and to your GLP-1 point, but just in general, Tim, a 75-year-old today, even adjusting for inflation, is consuming and spending far more on healthcare today than that same 75-year-old was 20 years ago. And it's largely because there's simply more on the menu, right? I mean, we're talking in the context of a pill right now, but there's just a lot more things that the healthcare industry is capable of fixing, curing, treating, managing. than it did 20 years ago. And 20 years ago, they could cure, fix, treat, manage a lot more things than they could 20 years before that. So as the menu gets larger, we're going to continue to spend more and more on healthcare. On top of the fact, of course, we still have this aging baby boomer population coming through the pipe. With we started this we sort of started this conversation from a technology standpoint somewhere around 2000 when technology really started getting interesting from a computer standpoint. And in those days, 1 in 8 Americans was a senior. And by the time we finish this conversation, 1 in 4 Americans is going to be a senior. So we have this double demand side issue where we have more seniors um, needing more health care. And those seniors have much more to choose from on that menu of healthcare services than they did in the past.
Well, good. And so I guess you're putting that into both the opportunity and threat column.
Absolutely is.
Okay.
Absolutely is.
And so just for the benefit of our audience who may not know, define GOP1.
Oh, the drugs, Ozempic and other drugs that were principally designed for treating diabetes, but have been very effective at weight loss. And I'm not arguing against that being a good thing. I mean, if we could knock down our obesity rates, it'd be a great thing. But right now, the expense of doing that is going to break society's piggy bank.
Yeah.
Yeah, we're going to get into that issue of society's piggy bank a little later. So Matt, what's your thought on this?
Yeah, it's not too dissimilar. I think though, instead of the cost, to me, it's much more on the access side. So I think, as Jay pointed out, Medicare enrollees continue to grow and become a larger segment. You have to be able to provide a lot more care for a lot more people. But the number of doctors isn't increasing at the same rate as the number of seniors enrolling in Medicare. And similarly with like rural healthcare. There's fewer doctors going in that area, but there are still lots of human beings that live, farther away from major hospitals. So that's both a major challenge just in general to provide the amount of healthcare that you need for all the people who need it with the current lack of human beings. But again, I see that as an opportunity as well. I do think that technology, even if it's expensive to begin with, can begin to address some of that.
Yeah, Matt talks about the doctor shortage. The doctor shortage only goes from bad to worse over the next 10, 15, 20 years. But so does almost every other healthcare worker. We also need nurses. We also need allied healthcare professionals like chiropractors and physical therapists and nutritionists, and we don't have enough of them now, and we won't have, and we'll even more not have enough of them. And the other half of my answer would have been what Matt touched on is it's not quite the haves and the have-nots, but it's really the big cities and rural. We really are starting to see the beginning of a crisis in rural America, places like Texas, Tennessee, Kansas, Mississippi. These communities are losing their rural hospitals. 20% of rural hospitals in America are financially vulnerable right now. I'm not saying 20% of them are going to go out of business, but a lot of them are going to either go out of business or be what the industry is calling hollowed out. So the building remains. Some people come to work in the building, and some healthcare is being provided, but it might no longer provide a service for a mom that needs to deliver a baby, or it may no longer provide chemotherapy, or it may no longer provide certain surgeries. So the physical building will still be there. It'll look like that community, that rural community has a hospital, but in fact, many of the services that it would have provided out of that hospital 10 years ago are no longer being provided, which means that community has to drive hundreds of miles to get to the nearest city that might have a healthcare facility that has the services they need in the form of a hospital or a health system.
Yeah, and I would guess that's where things like the teledoc movement that
Exactly. Yeah.
really came into its own during the pandemic,
Right.
but it goes way beyond the pandemic.
Right. That's the
Um,
opportunity, right? We have a lot of technologies that would, in no way, shape, or form, could the patient or the person or the senior have been able to manage their diseases from home or from a different care setting other than a hospital 20 or 25 years ago. But now, thanks to telehealth, thanks to remote patient monitoring, thanks to a lot of things that are AI enabled, you have a fighting chance to be able to live the life you want in the geography you want, despite the fact that you might be 600 or 800 miles away from the nearest full-fledged hospital.
Yeah, and I think one of the themes that may come out of today is this concept that it's not necessarily either the technology or the human. In a lot of cases, it's the two of them working together
Right.
to create a better outcome. Um, okay. Thanks for that intro. And Matt, I think that sets you up to talk about kind of basics. Give us a little basics of AI to begin with, and then we'll launch quickly into AI in healthcare.
Yeah, absolutely. All right. So that's me. So yeah, I have a PhD in computer science, and I've always focused on AI for about 20 years at this point, and specifically AI in healthcare. So the opinions here are kind of underpinned by my expertise in the field. Um, And so, I think it's useful. A lot of people just ask me how AI works. And so I'll just very, very quickly go over sort of the history of the field. And if you take nothing else away from this, it's really there are kind of three big blockbuster moments in our field. And the first one is people thought that, machines would be logical and follow rules like human beings do. And this is kind of the classic era of AI. And so, puzzles like a Sudoku puzzle can be solved by just encoding all the rules that determine how you can play the game. So you can't repeat numbers across the rows and the columns and within the squares. And these rules would be encoded in logical rules like you see here. And then you could solve a lot of problems. But people quickly realized that these problems were limited and that it might be useful to actually look at data and how you learn things. And so this is now the era of machine learning, which is more where I came up. And machine learning really kind of follows three large patterns. So the first one is what's called supervised machine learning. So here you're providing examples to the computer to learn from. So instead of just starting with rules that I, as the person, create myself, I'm going to give the machine a whole bunch of examples and it will learn from those examples how to do the thing. So this image is an x-ray of an arm and the arm is broken. This image is an x-ray of an arm and it's not broken. You do that a lot of times and you're providing those answers and the machine will learn how to do it. In contrast to what's called unsupervised learning. So with unsupervised learning, you're just looking at the data itself. So maybe you have two cohorts of patients in the healthcare system, one who, passed away before 50 and one who doesn't. And the machine is just going to try to figure out based on data around them, what that could possibly be and what the patterns are. And so maybe it was like heavy smokers and not heavy smokers. And then reinforcement learning is where the computer will make a mistake and learn from that mistake. Or maybe it does something well and it learns from that as well. So the example I often give here is a chessboard. So depending on the point of view of the pieces, you can always score a chessboard. So you take all the black pieces and they have a certain score relative to where they are on the board and all the white pieces. And if I'm playing black, I can take that board configuration and it gives me a score. And if I move a piece and that score improves, that was a good move. And if I move a piece and the score goes down, that was a bad move. And so that's how reinforcement learning works, because the machine is going to make little adjustments and then see if it did a good move or a bad move and then learn from that. And now we're in the era of deep learning. And deep learning is basically these types of techniques, but at massive, massive scale. So entire data centers full of machines that can do these supervised, unsupervised, and reinforcement techniques. And we call these, when they're looking at text, we call them large language models. And this is what most people think of when they think of AI these days, which is, a chat GPT or a Claude or something like that. And so the way the language models actually work is they're just trying to basically guess the next word. And if they do a good job of guessing the next word, then they're reinforced for that behavior. And if they do a bad job guessing the next word, then they're sort of punished for that behavior. And so the classic example is, you read the entire internet, so every web page that's ever been written, you feed it to the AI. The AI is going to learn to predict words, and you give it a task and you say, okay, the sky is, and hopefully it says blue. And all of us say blue because we've, been trained in that. That's kind of we call it the prior probability or the probability of seeing that. And if the machine says blue, it did a good job. But the big innovation is what we call conditioning the AI. So rather than the sky is blue, which is the default answer, if we say it was cold and rainy and the sky was blank, the machine should probably say something like gray or, overcast because it's been conditioned. It's taking into account the fact that we said the world was cold and rainy. And so that's the underpinning of all of these language models that you play with, ChatGPT and all this kind of stuff. So they have some more sophisticated techniques they've layered on, but that's kind of the core one. And so, when we do that over text, so reading the entire internet or reading all of Wikipedia, we call it a large language model. And what we've been able to do is then give these types of techniques different sorts of data, and then, different emergent behaviors happen. So when we give it all of the programming code, so the software that people have written to produce the programs themselves, the model will actually learn to generate code. So whereas before it's generating text, now it's generating code. You can give it lots and lots of data about the world, and it can start to figure out physics. And then you can begin to combine these into what's called a mixture of experts. And so a mixture of experts is essentially a kind of like a big model that can do lots of things and knows how to route for the appropriate task. So if you ask it for a haiku, it will use the LLM. If you ask it to write a web page, it will use code. And there's some idea that maybe this is how a human brain works, which leads naturally to the next question of, AGI. So this is how some of the language models work. And what we've seen in the past couple of years is this following diagram, which came from Google, which leads us from when LLMs came out into the world about, chat, kind of GPT-3, people began to use them. And the way you use it is you would set a prompt. The prompt would do something interesting from the language model and produce an output. So maybe you saw an app that would write a haiku about a picture. And so all that's going to happen is there's a prompt with the picture. It goes into the language model. Out comes your haiku. And so, this was where we were a few years ago. And then people started to realize, well, what if I can hook my own data into the language model? So you have a language model and you have your own documents, say like, all of the legal memos that you have, or, the lyrics for every Rolling Stone song or whatever it is. And now you ask a prompt, the prompt is going to incorporate your data and then give you the answer. And we call this retrieval augmented generation, RAG. And then people said, well, that's great. You have your own data and you have the ability to kind of, chat and do all these things. What if we give tools? So maybe, instead of the AI model just reasoning over my data and the language, maybe it can go out on the internet and click things and get results back. Maybe it can query PubMed for every single article that exists. Maybe it has a long-term memory about all the interactions I've had, and so it can do all that as well. And that's what we call an agent. So the big difference between these models like ChatGPT and an agent is the agent can do a lot more things on your behalf. And now where we are is this kind of world of agentic AI, and you hear this a lot. And so what this means is my prompt comes in and I have a bunch of agents. So each of these agents independently can do certain things like, act with all these tools. They have their own memory, and then sometimes they're specialized. So maybe one agent's really, really good at searching PubMed, and another agent's really, really good at doing all the statistics on the results from PubMed. And so rather than having just one agent do both, you have them, kind of coordinate, and you get kind of an economy of scale in the same way that humans tend to organize. So we go from language model, which gives you an answer from the model directly, to adding our own data, which is what's called RAG, to adding tools to that data, which is an agent, to having multiple agents, which is agentic AI.
So let's talk for a second about the security of the data. I know in our Age of Disruption workshops that comes up quite a bit. And so there are ways in the traditional ChatGPT, Claude, and some of the other AI tools to make sure that it's not sharing your data out into the wild, into the world. And we reinforce how to create those security protocols. But I guess, Matt, the question is, as you're getting down this list, and we're right on the cusp of an explosion on the agentic AI side, and again, healthcare may be a pretty interesting use of that. How secure is your data, even if you set up the protocol to say, oh, I want it walled off so it's not shared with the rest of the world?
Yeah, it's a great question. And there's security in two ways here. So the one is the security of the data itself, like you don't want it to go out. The other is the security of the agent. You don't want the agent to go off the rails. And in fact, we just published a paper, myself and a few scientific colleagues, a few weeks ago. We call it the don't push the red button problem. So you can imagine a big red button that says don't push. The agents will sometimes push that button. And so how can you add a security framework around that so that they don't do that? So that's one aspect of security, like don't do anything bad with my data. And the other is the actual security of the data itself. Don't let it leak. Don't share it impermissibly, things like that. And it really depends. So you can imagine sort of the walled garden around the entire universe of the agents. And so, everything that works within certain like HIPAA compliant frameworks like Claude's Health and OpenAI's Health, you're assuming that the contract they have within that whole universe is fine. And so if the agent is never allowed to use tools to go outside of that or communicate with anything outside of that, in theory, it should be good. And sometimes that's not good enough. So sometimes what people will do is use what are called self-hosted models. And so in this case, you're using an AI model, but not one that's provided by any of the big providers. You can actually use it yourself. So you have your own computer that you control somewhere, you put the AI on that, and then you can have agents interact only within that environment, and you're much more confident that nothing will leak outside, assuming again that you haven't done any kind of tooling that lets the agent communicate with the outside world. So we call that an air-gapped solution. But even then, sometimes people aren't comfortable with the data floating up and down. And so, what people will do is redact any personal information prior to sending it over the wire. So it's very, very possible that, you can look at the medical record and get, symptoms and lab results and everything and still redact all the information about the person to a much higher, more general level, and then use that for whatever tooling you're doing. And in fact, I think it was just yesterday, OpenAI says that they released a state-of-the-art model for redacting personal information. So clearly that's important to them as well. And it underpins a lot of what they're doing on the health side. So what it comes down to is if you're using one of these models that are commercially hosted, do you trust their policy to be enforced as strictly as they say it will? And, I think that, it's a personal decision. If you don't, you can use these, and you're a company, you can do these kind of self-hosted air gap techniques. And then if you don't trust that, you can try to scrub all the data as much as you can. Now, you as a patient, just really will have to decide what that sort of cost benefit is of putting your own data into these types of systems. I mean, I've seen amazing anecdotes of people getting a lot of benefit from these models. And the flip side is, you do have to provide them with enough information to make that assessment for you. So, it really comes down to trust in their guardrails. And then there are some things you can do yourself if you have the technical capability or your company hosting that data.
Yeah, well, thanks for that explanation. I think the next few years, folks, you're probably going to see 100 articles on this very topic, and particularly when it comes to healthcare and some of the rules around sharing healthcare information, HIPAA, and so forth. So, all right, let's move along.
Sure. So the next natural question is, where are we on this scale? So we have these agentic AIs, but where are the models in terms of what's called artificial general intelligence? And so, the easiest way to think about this is, I suppose, a benevolent Terminator robot. So, this is an AI that can do anything that you can do as a person. And as scientists, a few issues arise. So one is we don't really know what it means for something to be artificially generally intelligent. Is it as smart as a person? But what does that mean? Is that person an adult or a child? Do you want the AI to be smarter than the smartest person or smarter than sort of the least smart human being alive? Like there's such a spectrum of what we call intelligence, and it's really hard to know. And so many folks say, oh, you'll know it when you see it kind of thing. But without having a crisp definition, it's hard to know if we've sort of crossed that threshold or not. And an interesting artifact that you'll start to see out in the world, when you look at a lot of the press releases that are coming from these large AI companies, they've started to talk much more about superintelligence, which is a term they like to use. So, this new model is a superintelligence for programming or superintelligence for cybersecurity or superintelligence for drug discovery. And they're deliberately no longer using the term artificial general intelligence, AGI, in these contexts. And the reason why is that a superintelligence is very good at some things, like chemistry or programming, whereas, an AGI is sort of reserved for something that's good at anything. And the reason we're not yet at an AGI is there are a number of areas that we just haven't made a lot of progress, or making some progress, which you see down below. And I think these are some of the key sort of stumbling blocks or hurdles to overcome to really get to AGI. And so the first one is the models don't really understand how the real world works. So you can ask the model, about a bowling ball falling, and it will, try to apply, some of the math there and understand what the physics is, but it doesn't really understand. And in the same way that you intuitively aren't going to walk into a wall, the model doesn't really know that unless you've explicitly told it. And so people have started to address this in two ways. So the first one is to come up with what are called world models. So you try to model the physics of the real world as much as you possibly can, and then those interactions will actually train the model. So you're not explicitly telling the model, here's how gravity works. You're sort of letting it explore in the space. And a very interesting example are the Waymo autonomous cabs that are from the Waymo Google company. They have a world model of just driving. So all it can do in this world model is, there are roads and other cars and pedestrians and some weather patterns and some interesting things. But it's very, very detailed, like, to the point where sort of tires can slip and all this kind of stuff. And they use it to train their autonomous cab for, different scenarios that are pretty rare to happen in real life. So you want the autonomous car to know what to do in an earthquake, for instance, whether it should pull over or go away, whatever it may be. But the odds of there being a Waymo during an earthquake to learn from are quite low. So you build a world model, you induce an earthquake in the world model, and you teach the robot how to do, what it's supposed to do. And it's all in software. So they're not actually, building like a building to do this with the actual robot. It's all in software. It's a simulation. And that's one way to teach these models about the real world. The other way is to sort of build it from first principles. So teach it everything you can about math, and then it will learn physics, and from physics, it will learn about the world. So there is some progress there. A big challenge, though, is, as I mentioned, these models view the world sort of like a chessboard. So there's some quantitative way to say that you're doing better at something or worse at something. And the way that, human beings learn, I think, is not that way. So, there are often times that we as human beings will make decisions that are simultaneously a good decision and a bad decision, and we'll continue and learn from that. So, for instance, you may be hungry and you make a poor decision and you eat a piece of candy instead of eating an apple. And simultaneously, it's a good decision because you're satiated, but it's a bad decision because you made a poor nutrition choice. But these models can't adjust that way. They can only kind of say, oh, this decision I made was better than that other decision I made. And it's unclear, if that's really what will lead to learning, and importantly, self-reinforcement learning. So babies are very good at exploring the world and understanding how it goes. And it's not clear that when, a baby, reaches for the spoon and spills it, and they're simultaneously happy because they learned how to reach for a spoon and upset because they don't have food anymore. That kind of learning isn't yet encoded in these models, but it's very important because the baby can learn very, very rapidly by exploring the world autonomously. Which leads actually to the second point here, which is these new architectures. So as I mentioned, we're sort of reductive in that a lot of the learning happens by quantifying if something is good or bad. And that's just the nature of the math behind how these AI models have been built. So some people are starting to explore totally different architectures that maybe can even do some of the self-reinforcement learning we've been talking about. But until we get to that point, it's unclear whether we can really have something that can do any task. And so, I'll skip over embodiment for a second here, but the biggest hurdle that we have is generalizability. So we as human beings can do anything. It's just a spectrum of how good we are at that thing. So anybody listening to this call and the four of us, we could all theoretically go play an NBA basketball game. We just wouldn't do a very good job. Well, maybe some of you will, but I certainly wouldn't do a good job. Or we can give any pieces, like if you have a children, sometimes they'll invent a game and they'll just give you pieces and sort of tell you rules, and then you go and you play that game. So you can do almost anything as a human being. It's just a degree of how good you are. The machines cannot. So the Waymo car that's driving around isn't going to play chess, and it's not going to write the haiku. And GPT, which will write the haiku, is not going to drive the car. They're still very kind of siloed in what they can do, even though they can do lots and lots of amazing things. And so that's the biggest hurdle. And it's unclear the way we've currently built these techniques if they can generalize. I put a big sort of blank, instead of a green, yellow, or red for embodiment, because I'm not a philosopher, so I don't know enough about this. But something that I think probably AGI will lack is embodiment. So, there are a lot of people who don't, they argue that we're incapable of separating intelligence from having a consciousness. And if that's true, then we need to figure out really scientifically what that means and how to imbue that in. And the reason why that's important is, in particular, it ties into self-reinforcement learning. So humans are self-preserving. You have scales of altruism and all these kind of things, and they have ethics, and that dictates both learning and behavior to human beings. And so, if we don't have that, it's unclear, to us as scientists whether we can get to true intelligence without it.
So the way this relates to healthcare is that in the near future, are you saying it's more likely that the tools that we have are much more specialized?
Yeah, I believe that to be the case. And that's not a bad thing. You may want the machine to do something very precisely that it's very, very good at, and not sort of debate all these other techniques or go off the rails learning something that may be inappropriate, right? Especially if we're not clear at what level an AGI is. You probably don't want a teenage doctor, unless it's Doogie Howser, equivalent AI making a decision versus something that's, super intelligent, a super intelligence that's able to, diagnose sepsis or something like that. So I think for now we're on this path of I call it broad specialization because it's not so precise. These machines are very good at lots of tasks, but not yet full generalizability. And so that's why you do see AI that, I think is going to be a bit more specialized than just sort of, one that can do everything. I don't envision a near-term future where, the car that picks you up from your house to drive you to the clinic simultaneously can diagnose you on the way and provide a care plan when you get there that it passes off to something else. I think that's many AI capabilities glued into one. So that's a future scenario.
Yeah, and my experience has been most of our audience has probably used their favorite AI, whether it's Chat or Copilot or Claude or one of the other ones, to ask a medical question, but some of them perhaps didn't ask the question the right way, and so they've learned to ask the question different ways, and then the the new AIs, new literally in the last year, and in some cases last 3 months, will then trigger you to ask the next logical question, the question you may not know to ask, but they're sort of prompting you to ask. And so I guess the generalized piece is here, but the question is it always spot on? And for medical professionals who are watching, I know that you lament to me all the time about uh, patients coming in with Dr. Google answers. Well, now they're coming in with Dr. Chat answers and Dr. Copilot answers.
And
And
that goes
Dennis,
back.
when you think about all the places that AI reaches out to get us information out in the web, and then you think about what kind of junk there is in the medical world out in the web and differences of opinion, it does frighten medical professionals that people would seek answers, uh, healthcare answers, and trust that healthcare answer through AI rather than through someone who has the ability to discern junk that's out there. And there's a lot of medical junk available for people.
Yeah,
Yeah, and
good
it
point.
also goes back to Dennis's point about our concern or lack of concern around our own healthcare data. Dr. Google for a long time has been able to give you a generalized answer about something without taking into consideration who you are. ChatGPT could, in theory, and in some cases does, ingest your entire electronic medical record. And then you ask it its question, then you ask it the question that you could have asked Dr. Google 10 years ago, but Dr. Google just gives you the generic answer. It doesn't even know if you're male or female. It doesn't know if you're 65 or 15. It doesn't know if you have blonde hair or brown hair. ChatGPT could take in your electronic medical record, now ask it the exact same question, and it's far more likely to give you accurate, actionable information because it knows far more about you in the first place. That's a very big, profound difference.
Matt, take us from AI up here in healthcare to more specific use cases. An example that I've used is in radiology. We have for many years been using uh, now what you would call it AI to assist radiologists. It's not displacing the radiologists. There was a fear of that, but it's telling them which of those multiple CT scan slices to focus on.
Yep.
And same thing in derm path, and same thing in other areas where there's so much information. Um, Modern radiologists would not think of trying to read scans without that assistance. So where do you see some real impact already?
Yeah, the radiology is certainly one. And an interesting phenomenon is that there's actually more radiology as AI is being deployed and more demand for radiologists to work in conjunction with a lot of the machines. And so within radiology and imaging in general, the Jay has a good quote, sort of the human eye and the human ear is relatively limited, but sort of the AI eye and the AI ear is much less limited. So in imaging, you're seeing a lot of more polyps and scopes than the human eye can find with the AI. You're seeing more regions to focus on and helping be more efficient, like you're pointing out when you're reading scans. Some companies are even just formulating, the note in the language or in the voice of the radiologist for them to sign off on, so that you can kind of eliminate some of the administrative burden associated with that. So there's certainly cases. In radiology, and then diagnostic imaging as well. So, skin cancer companies now have gotten pretty advanced with some of these tools that can, look deeply at what's going on. And then surgical planning is another really interesting one, where people are making essentially virtual copies of the human being, ahead of the surgery and planning it out. And the AI helps kind of shift and sort of determine what could happen in the digital twin, they call it, of the patient and their particular organs. So, there's a tremendous amount of kind of seeing more, I guess, than what the human being can see, and helping the human to really focus down and predict what could happen. And in some sense, it's not too dissimilar to kind of lessening the administrative burden, but really on the administrative for the human being side. Scribe is another example where you see just tremendous adoption. So there's these ambient scribe systems, and they're sort of listening and transcribing notes. And the thing that they do that's most interesting that we as humans take for granted is that there are multiple people speaking in those situations, and the AI is able to distinguish who is speaking about the question and the answer, and how that then goes into the note. And that's actually one of the big innovations, surprisingly, is just understanding. We call it the cocktail party problem. So who are all the different speakers and how do they associate?
And Matt, I think it's the first time in my career where physicians aren't complaining about a breakthrough in technology, because we've layered on computer systems and they've become typists. They've had to do so much more late night uh, record keeping than they used to do. And so now finally with Scribe and some of these things, they're much more sensitive and come out with a note that really does work. It is taking some burden off.
Yeah, I think that's right. And I think it's also speaks a bit to some of the maturity in the innovation ecosystem. So traditionally, technologists will often think that they can come in and innovate in any industry. And they're like, here's my amazing solution. You should just use it because it's so much better. But obviously in healthcare, there's just so much workflow specific activity, and you don't want to add burden. Like a doctor shouldn't have to go from typing in the EMR to typing in my other system on this other tab. And I think that a lot of the technology companies have become more mindful of how they glue into existing workflows, so that they're lowering both the workflow burden and kind of increasing the capability based on the tool that they're doing.
Thank you.
Yeah.
Uh, Jay, any examples come to mind in your case?
Yeah, lots, and I am glad that we're spending a little bit of time talking about the administrative side. It's not as fun to think about, but at the end of the day, we all, whether we're in the healthcare industry or not, we hear the statistics. We're aware of how much time since we transitioned from paper, pencil, file cabinets, which wasn't all that long ago, right? It wasn't that long ago that you went to your doctor's office and behind the receptionist were those gray or tan file cabinets, and that's where all of your healthcare information was. And then we spent a good 15 or 20 years in the United States getting our healthcare industry to convert that from paper to pencil, or from paper and pencil to digital. But the administrative side, if we could do nothing else, and certainly we are doing more than nothing else, but if we could just use AI to get some of the administrative burden off the shoulders of our doctors, our nurses, our allied healthcare professionals, that's very, very important. And that's where a lot of the early breakthrough has come. In the early innings of AI, as it relates to healthcare, we were doing a lot of work around the administrative side of healthcare. And then in my view, as we got more confident, we've started to let our AI imagination go after the more clinical parts of healthcare. It's starting largely, as Matt's slide here in the lower right talks about, around diagnosis. But there are lots of technologies out there that if they are paying attention to you, and it doesn't, and the thing I'll add to your question, Dennis, is that it doesn't have to be technologies that you're experiencing inside the clinic or inside the four walls of a hospital. Increasingly, there are technologies that you can bring home. It can be the Ring, it can be the smartwatch, it could be the Fitbit, it could be devices that you have installed in your house, and those devices are keeping their watchful eyes on you and seeing and being able to predict a health episode before it happens. You're 75 years old, you have three or four technologies installed in your home that are able to detect that you're on the verge of a UTI, maybe 2 or 3 days before that UTI is detectable to you, the person. Now, all of a sudden, a phone call can be placed into the home and say, Mrs. Smith, Mr. Smith, we think you have a UTI. You probably aren't even aware. You probably aren't even feeling differently yet, but we have some technology that is predicting it. Let's get you to urgent care today as opposed to waiting till it's flared up and then you're going to the emergency room. You'd rather go to the urgent care versus the emergency room. And whoever's paying for your health care would rather you go to urgent care versus the emergency room. One's going to cost society $300, and the other one's going to cost society $5,000. So the thing I'm adding on to this is to think about the value of this technology in the healthcare settings, hospitals, skilled nursing, clinics, physical therapy centers, but also in your own home. A lot of this can be brought into the home today in a way that creates profound benefit value to the person, the consumer, the patient, in a way that couldn't have happened 10, 20 years ago.
Jay, I used to joke. A friend of mine was the CEO of United Healthcare in North and South Carolina, and they had a 300-person office building about 3 miles from my 300-person office building. Mine was to bill them, and his was to deny the claims.
Yeah.
It's just like, so can't we figure this out? And I think AI is
Yeah.
starting to see some breakthroughs in how we adjudicate claims because we dealt with 300 or 400 different healthcare plans. Every was, a little bit unique and had different denials and different rules. So complex. Now with AI, we can sort through those things much, much easier.
Yeah,
Well, and we're
they're developing AI on both sides. There's a great story about a hospital that's using AI to reach out to the insurance company, only to find out that their AI is not talking to a human at the insurance company. They're talking to an AI at the insurance company, and then you have two AIs talking to each other. And
Yeah.
now we've entered into a world that Matt's been predicting for probably many years, where they no longer need to use English. They can be talking in zeros and ones and get to the bottom of the claim a lot faster, a lot more efficiently, hopefully.
so many questions on that issue alone.
Yeah, I'm
We'll leave
sure.
that for a future edition of this. And Tim, I know for many years you've been a proponent of more preventative medicine. So it sounds like some of these things we've been talking about maybe up the ante to do better preventative care.
Yes, we're using a startup company to capture patients' lab work in pharmacies. So you go to the pharmacy and it's free for you, and we'll run your lab work, and then we can reach out and say, "Hey, do you know you have XYZ? Here's an
Right.
office appointment for you."
Right.
And we're finally. I started earlier by talking about the disparities in healthcare, how our longevity's 4 years less than the rest of the world. Our longevity in Greensboro, North Carolina, 300,000 people, from East Greensboro to Northwest Greensboro is about 10 years.
Wow.
East Greensboro is a healthcare desert. So we're starting to finally, to Jay's point, deploy some of these technologies and to get care out in parts of our community that have not had care and populations that haven't been cared for.
Let's spend a minute talking about the piggy bank. And so under access, you have Medicare 10 times productivity required. Um, uh, we do a lot of work on AI and the national debt. So will that productivity come before we're broke for the national debt?
It might be. If you go back to which I did on a rainy day a few years ago, you go back to about the time that I graduated from high school, and you look at the productivity increase of the average worker in America across all of our industries. I graduated from high school in 1987, about the time that the thing we now call a computer was coming of age. And then we get the computer and we get the internet and we get mobile and data, cloud, SaaS, and now AI. So a whole bunch of technology has been put in place in society over that 40-year time frame. Not surprising, the average worker in America's productivity, as detailed by the U.S. Bureau of Labor Statistics, went up 5.1% year over year. So whether you were a teacher, whether you were working in Wall Street, whether you were working in advertising, your average productivity went up 5.1%. That same time frame, about the time I graduated from high school, if you were a healthcare worker, your productivity went up 0.4% year over year. It's a dramatic difference. Now, that's looking at all healthcare jobs and comparing it to all jobs, period. But 5.1% year over year, if you think of it as compounding growth, compared to 0.4% year over year compounding growth, means the average healthcare worker is negligibly more productive today than they were 40 years ago. Conversely, the average lawyer, the average paralegal, the average construction worker, the average teacher, the average Wall Street stockbroker, their productivity is markedly greater today than it was 40 years ago. So I do think that, good news, healthcare has been holding back. So it's got an opportunity to slingshot and pick up perhaps more productivity gains over the next 10 years compared to other industries, because it's been holding itself back and not embracing all things digital as much as other industries had.
Jay, I used to love to pick fights with my nursing colleagues by pointing out the fact that we're using the same nursing model of care we used 40 years ago.
Right.
We talk about nurse patient ratios. We even, places like California legislate nurse patient
I
ratios,
know.
but we don't think about the impact that technology can have
Yeah.
to allow that nurse to be more productive and to get some of those gains that you
Yeah.
mentioned and to improve the quality of their daily work. There's a lot of things that we have nurses doing that they don't need to be doing.
We haven't adjusted the number of years that it takes to make a doctor. We need more doctors in this country, but it takes 12 years to make a doctor. Maybe we could let that be done in 11 years and get doctors to be made faster. We're going to need more doctors regardless of what technology does over the next 5 or 10 years. When it takes 12 years to make that labor unit called a doctor, maybe shortening the amount of time, given how much support the doctor gets today that the doctor wouldn't have gotten in the 1960s or 1970s or 1980s, because they wouldn't have had any technology at their disposal.
Well, Tim, I'm curious because you have seen a lot of these issues from multiple points of view, patient point of view, physician point of view, administrator point of view. You've done it at the local level, you've done it at the national level. Is there any reason to believe that 0.4% productivity increase Jay talked about will get better in the next 5 to 10 years?
Oh, I'm hopeful. I'm always hopeful. I think we were talking about the cost issue. I think we have more than enough money in terms of the percentage of our GDP being spent on healthcare. We just got to rethink how we deploy it. And Jay pointed out, choosing that urgent care versus emergency room visit. And there's just lots of ways that we default to the most expensive model. An example I use is when we first formed an ACO, accountable care organization, 15 years ago. Our first group of Medicare patients that came into our management, we found one lady that had been to the emergency room 100 times in one year. No one had noticed because she went to a different ER every 3 days.
That's right.
And she was a below the knee amputee. She needed a wheelchair ramp built for her. She didn't have a refrigerator for her insulin, so she didn't take her insulin. And what we worked on were social interventions, getting a church to build a wheelchair ramp, buying her a dorm-sized refrigerator, getting a home care company to go check on her, getting a church Meals on Wheels to deliver meals. And she didn't go to the ER the next year in the first 6 months. And think of what we saved in terms of cost to Medicare and Medicaid. She was dual certified, and and her quality of life. But those are sometimes, I mean, Matt, those are the kinds of drill downs that we can do by looking at big data sets.
That's right.
Yeah, that's right. And healthcare is so particularly ripe for AI, to Jay's slingshot point. So, very few industries have so much data that is so valuable that's locked away and unintegrated. So, just ready to be fed to the AI to do all this amazing stuff. So I do think that, a lot of that will increase the productivity and kind of do the slingshot. And, again, to kind of Jay's example where he always talks about, the lack of what we can see and what we can hear, when the stethoscope is on your chest, the doctor's listening to, the 5 or 6 seconds that they've heard. Whereas, if you have some kind of remote monitoring or ambient solution, the ears of the AI can be everywhere and much more deep. Same, when you're looking at the scope, you're seeing what you can see through the eye of the scope, which is relatively limited, whereas the AI can look at the entire thing all the time. And so, I think the combination of just this rich data that's sitting there to be integrated and kind of the human machine teaming, as we call it, to Dennis's point, where, the doctors are really working with the AI, where the AI can excel and kind of turbocharge the doctor, those are just going to make, tremendous gains. I'm opportunistic as well, but there are some risks, obviously. People will need to learn to trust the computer, just, and in the same way that, you trust autopilot on your car. If you do, there can be misaligned incentives between, companies trying to maximize their payment for the AI service, and, just in the same way that you can in any kind of misaligned incentive in healthcare. And I think liability is also going to be a very, very big issue going forward. So if something, God forbid, does go wrong, who has to kind of take the blame and deal with that? But, I think that this industry is just so ripe for AI, just given all these factors that sort of, it not only has to happen, given the productivity that's required for all the Medicare patients, I think that it certainly will.
And you used the word continuous earlier, Matt, and that's one of the places that I'm personally very excited about. I think about I think all the people that are watching this video probably relate to a time in their life where their car is making a funny sound. They decide to finally, it's bothering them enough, they decide to finally take it to their mechanic. And lo and behold, when the car is with the mechanic, the car is not making the funny sound. We've all had that experience in life. The mechanic can't figure out what's wrong, so then you take your car back, and then Murphy's Law, 3 days later, the car's making the funny sound again. Well, what about our own bodies? Our body is the car. I've got the wheezing coming out of some part of my body, wheezing in my lungs. I go to the doctor, and to Matt's point, doctor's going to listen to my chest or my heart or some body part for 5 or 6 seconds. And if it doesn't happen to wheeze at that moment, the opportunity to diagnose is probably gone down dramatically from a likelihood standpoint. Now I can have a doctor continuously listening to my chest if I want that. I can put that patch on my chest. I can go home. The machine can get 48 hours of continuous data that can be run through an algorithm. And now the doctor can look at the results of that readout, as opposed to following me around in the old world. They could have followed me around for 48 hours with a stethoscope on my chest. Now the machine is doing it. There's probably a lot of avoidance of escalated medical issues if we can be continuously monitoring certain parts of the population of the United States that's at risk for X, Y, and Z. We could have never done that in the old days, and that's going to keep people healthier. That's going to keep them out of the emergency room because we're going to catch things earlier than we otherwise would have caught them.
Matt or Jay, can I ask you a question of, have you seen, we've been talking about the ability to have AI help clinicians and help hospitals and help, overall. Do you have examples of where you see a consumer benefit, direct to consumer? I have wondered if it couldn't be, I'll just, go try to find the cost of an MRI in your community.
Right.
I mean, you can't do it. I mean, do you see where consumers can directly benefit? Jay, obviously, the examples of remote monitoring, some of those things. Yes, certainly. But Matt, what do you see for consumers of healthcare? Because one of the common complaints we get is it's so hard to navigate the healthcare system.
Yeah, that absolutely. So I do. So remote monitoring, as you mentioned, is a really good example, and in some sense, getting ahead of major healthcare issues preventatively, like the UTI example. So we've definitely seen companies that do interesting things there. I think there are even some really good preventative therapies that seem pretty simple on the phone. So one of my favorite examples, and there's a whole host of these, are the apps where you can just take a picture of what's on your plate and it can identify the food and give you things related to salt content, or calories and things like that.
I don't want to do that.
Yeah, fair. That's a choice, right? You know what? Well, the machine isn't judgmental, so that's good.
Oh, okay.
It's some of those can help prevent people, like limit some of their salt intake overall. Even just getting kind of more educated, having a conversation. You don't even have to update, providing your medical record, but just having a conversation with some of these tools about, the current diagnosis you have and the treatment plans can even be helpful. And it is much better than Dr. Google because you can have an interactive session like, hey, I don't entirely understand, why I'm getting a CAT scan on my brain, whereas well, non-Gemini. So all Google search will tell you is, it's common to get a CAT scan of your head with this condition for XYZ. But now you can interact and say, well, I don't know how to do that, or maybe I'm claustrophobic, and the machine will say, well, then you should definitely ask about, having some kind of, relaxation, medication ahead of it, whatever it may be. So you can get a better sense of what the plan is for you, so you have the right questions to ask. And you can even begin to ask, if cost makes more sense. Should I get my MRI, in the inpatient outpatient facility, or should I go to a, full freestanding, imaging center because it will probably be cheaper? And start to ask these questions with the AI. And I think that there's enough training for them that they can begin to give you, reasonable starting points. These aren't final answers. You should probably go talk to somebody about them, but you can get much more informed. I kind of liken it to people have gotten so much more informed on everything that they purchase, like shoes and whatnot, just because there's a huge volume of information that you as a human can find. That's much harder in healthcare. Like there's just so much jargon you have to understand. There's so much sequencing of navigation that you have to understand. And the AI can really help kind of bring it to the level of where you're at, in terms of the planning there. So yeah, but to your question, there's a lot of really interesting apps that can help kind of give you the information that you may need. There are a lot of really interesting remote monitoring, and there are patient-facing therapies. There's a company that has a robotic dog that helps, people with Alzheimer's, who want to maintain a connection with, with a pet, but they can't. And so, and that type of technology doesn't work unless the AI is strong enough to really mimic a human animal, because, the human being will obviously know if it's a stuffed animal, if it moves too robotically. So there are some pretty interesting patient facing advances. In fact, I think when I think of the spectrum of healthcare, there's obviously AI at the provider level, because that's what we all think of, which is AI doing some diagnosis. But there are a lot of really interesting AI companies at the payer level, helping insurance companies adjudicate claims. In fact, Claude has capabilities around this, to do some of the kind of prior authorization automatically. There are lots of patient-facing technologies that have AI embedded in them. Even as simple as, an automated walker that can, gyroscopically balance, that's machine learning in there. It's not AI in the way a chatbot is, but there's machine learning to make sure that it's keeping balance. And also on the pharma side, on the life sciences side, there's a lot of people doing
research
work. So, the whole spectrum, I think, is getting infused with this, which, will hopefully boost the productivity that we need.
Jay, I know without revealing, kind of de-identifying companies, do you have a AI enabled company that you're working with that you're really excited about?
Oh, first of all, so many, but Matt touched on it just a second ago. If you think about whether you're clinical or not, I think we could all agree that keeping our seniors mobile is a good thing. If we keep, and especially the advanced seniors, not necessarily 65.0, but you're 75, you're 85, or you're 95, less couch time, more moving around time is good, but mobility becomes an issue. A smart walker is a wonderful product for this particular case. We can keep our seniors moving around, going to the park, going to the shopping, doing their own shopping, maybe even getting on an airplane and going to Las Vegas and wandering around Las Vegas. Anything we can do to keep seniors, if you want the lowest, perhaps the lowest hanging fruit, it's keeping the body moving around at 75 and at 85 and at 95 and at 105 and someday at 125. We want to keep seniors moving around. So being able to embed AI into something as common as a walker, something that we see every day when we're wandering around. We see seniors or people recovering from a hip or a knee replacement surgery using a walker. If those walkers were smart, if those walkers were had the Tesla mentality built into them, that could make a huge difference. At the end of the day, though, it's all about value. I think about one of the most pedantic examples probably happens millions of times every day. I've got a headache. I'm not going to the drugstore, the pharmacy to buy a pill. What I want is headache relief. That's what I'm buying. And I'm trained to get Motrin, but Matt's an Excedrin guy and Tim's a Tylenol guy. And we're grabbing one off of the shelf with no particular scientific knowledge if that's the right pill to help us with our headache. But if our phone knew our medical record and there was enough sort of algorithmic work done, we could grab the right pill for our particular situation and increase the chances that 20 minutes later that headache is gone. So for me, my North Star is value, and there's value at the provider level, there's value at the payer level, but there's also value at the patient level, and ideally they all converge. Because what we want to do is spend as little as possible on that pill to get rid of our headache at that moment of truth. And AI and data can do that for us.
Yeah, you just swerved into the lane of precision medicine, which I think is
Yes,
going
exactly.
to, there's been a lot of talk about precision medicine, but the reality of it, I think, is on our doorstep. Uh, well, we're running short on time. So, Matt, why don't you uh, go to the final slide, actually, and then we'll just get everybody to kind of say what some of their thoughts are about how to be a smarter consumer of healthcare.
Absolutely. And I see, you meant this as the final slide?
Yes.
Yeah,
Yeah.
absolutely. So yeah, so this is my email. I am always happy and open to discuss all things AI, all things healthcare AI. So those out in internet world, please don't hesitate to reach out. I really do like to discuss these things all the time. Yeah, so that please don't hesitate to reach out, and then I'll let everybody else they can answer, and I suppose I'll go last.
Tim, I'll follow you.
So I think there is a lot of I would start to use the typical the AI tools that we have available now. Just start small and inquire and start to learn to iterate those questions. I've only done that in the last 6, 8 months, and yet I'm starting to really embrace that in my daily life on the decisions to make. I was talking to Dennis at lunch. My granddaughter was looking at several universities to go to, and she used AI to rank their engineering schools, their rocket clubs, because she is in a rocket club. She plays marimbas, and she wanted ranked on student life, and she had about 6 criteria. And it came out with a 9-page report and ranking the schools, and it really helped her to kind of narrow down her choices. And so I start to think about that, and I think about in our daily lives, what decisions do we make, like what headache drug to buy, Jay, where we don't really look at there's all that data, all that information's out there. We just haven't had a way to sort it. So I've just only in the last, I'm meeting my brother who's a Canadian up in Prince Edward Island. So I put in, give me a 3-day agenda for Prince Edward Island and 4 days on Newfoundland. My brother likes to drink beer and go to the pubs. And within 15 seconds, I had this trip planned.
Yeah, it's amazing.
And I sent it to him. He said, I can't believe you put all this work into it. I haven't told him yet that I didn't do a thing.
I have two answers to your question, Dennis. The
Yep.
first one I use quite a bit. I encourage people, whether you're whether you're 18 or 88, if you're in a city that has Waymo, go take a Waymo ride. And the reason I do that
Ah,
is I don't necessarily want to steal business away from the taxi cab or the Uber, but there's an experience that comes from being in the back seat of a car that's driving you around San Francisco or driving you around New York or driving you around West Los Angeles that gives you a concentrated dose of where this thing's going. And I can't think of a better way to let your mind open up to this, then you don't even have to, it doesn't even need to take you to your destination. Just go for a 20-minute ride someplace and experience what you're and be present and take note of what you're feeling while this car is driving you around. Um, is profound. The other thing is a little bit of what Tim said. You don't have to jump in with both feet on this AI stuff. I don't think that's what we did. I try to remember back where I was the day I logged on with my first website or the day I got my first email address and sent somebody an email. I'm sure I did a toe dip. And then I got a little bit more comfortable and I checked out eBay. And then maybe I found out what the Dodger score was at that night. Same thing. I have a friend who just had a shoulder surgery. He didn't download his entire electronic medical record into one of the large language models, but he did take the MRI of his shoulder, which was really messed up, got the MRI, loaded it in, asked let's say it was ChatGPT, asked ChatGPT to tell him what it thought was going on with his shoulder. The problem in his case was he wasn't going to be able to see his surgeon for 10 days. The surgeon was on vacation for spring break, I think it was. So he didn't want to be without any sense of what was going on with his shoulder for 10 days. So he asked ChatGPT what it thought, printed it out. 10 days later, the surgeon comes back. Surgeon says, then my friend said, "Oh, I'll share with you what ChatGPT said." Surgeon said, "Spot on, exactly." Just a very, simple, physically constrained example. Didn't have to download every single thing that's gone on in his health history for his whole life. Didn't have to worry about too much information getting into the world of these large language models, but was able to get an experience with this AI. I just encourage people, whether it's a toe dip or a full foot or all your leg all the way in, start to get some experience with it because the relationship you have with the healthcare industry of the United States is going to change. And all of us, one way or another, are going to have some relationship with the healthcare industry. You might want to start getting ahead of where it's going just by experiencing it as a consumer or a patient.
Yeah, very good. I think we all wish for the day that this agentic explosion that's happening, that we have our little healthcare agent sitting on our shoulder
We will.
who is not necessarily making the decisions for us, but helping us understand better what the decisions we're making are.
Yeah.
And we're not that far off from that. Had we had 2.5 hours for this. Matt has a whole series of slides of how the capabilities of everything we've been talking about are going up like a ballistic missile right now. They're just getting better and better. I mean, almost literally every week, something new is getting better. So stay tuned, folks. I'm sure that when we have another one of these 3 or 6 months from now, it'll be more gee whiz things to report. And again, the hope is that all of our health cares will be better as a result. So again, I'd like to say thanks to Jay, Matt, Tim. Lots of very good perspective, a lot of material in a relatively short period of time. Thank you for helping our audience understand this topic better.
Thank you, Dennis.
Yeah, thank you.